So let's talk about patient selection. So what percentage of your patients are you doing as an outpatient, and how do you make that determination on patient selection, and has that evolved since you have started doing outpatient total joints?
We really had some criteria that we were using as selections, and then we started to, a little bit as we get more and more comfortable, sort of make this a little bit more general, so that I think we started at 30 BMI and now we're at 35. But in my opinion, the most important is to have somebody at home to take care of them, because if they don't, it's not gonna work. I think maybe around 30% of my patients are at ASC now.
Is the patient reliable? Are they on chronic pain meds? Are they smokers? All of those things I think gives you an overall picture of your feeling for the patient, using the criteria, but also using kind of my gut and my interaction with the patient too. If you are in doubt, call Dr. Peters.
To Louis' point, we started with ASA 1 and 2 patients only. That was our cutoff. December of 2020, the hospital shut down again because I think we were getting a lot of requests from surgeons. Can you look at this patient? Can we do it? And I think that's where the shift happened for us, because we realized, we've been doing ASA 1 and 2 patients. They do really well. For some of these patients, getting a total knee, is sort of a life-changing event for them. They just want to get back to playing golf again, or hanging out with their grandkids or whatnot without having pain. I think that there's a lot of potential there. One thing initially that we always went into, we cannot have a complication, if things have to go perfectly. And I think if you think about that all the time, then you'll never take that next step. I think patient safety comes first. We have checks and balances in place, and I think you have to accept that once in a while a patient may need to get transferred. And I think if you have the right safety mechanisms in place, then I think that's just something that you have to realize that may happen once in a while.
And do you see that changing, or you think COVID has changed things permanently?
No, I think the hospitals, the traditional hospital setting, the way we've had it for the past 20, 30 years, I think that's a dinosaur. I think the outpatient centers is really where it's going to be happening at, and that's where the energy is. So the hospitals are they're too top heavy. There are too many fixed costs built into the system. They can't adapt fast enough. I think we're doing it more cost effectively, and ultimately it's about adding value back to the patients, and I think we can do it better at an outpatient center than the hospital can.
So one of the big things about making this all happen is pain management. So key for transitioning patients home, same day or the next day. I know more and more of your patients are going home same day. So what's the secret sauce that you've been figuring out?
Well, I think it's twofold. I think local anesthetics has really changed the game over the past couple of years. And then the other thing that both the surgeons mentioned, which is patient expectation. If they're thinking that it's just going to be pain-free for the next 3 days and lie in bed, I think that's not the right patient. You can manage it appropriately and know what the patient has the right expectations right up front. Just anecdotally, I think our patients are doing much better with that. I think the surgeons are have also changed over the years, where back in the day they just did whatever they did and patients stayed in the hospital for 3 days on a morphine drip or whatever. And that's not happening anymore. And so they're doing whatever they are doing in the joint to add additional local anesthetic and getting patients on medication pre-surgery already. So pain medication from the beginning right through the end, even when they go home, they know with the right protocol. So I think just awareness from surgeon to anesthesiologist to patient, and in a combination with some of the newer medications we have, I think that's changed the game.
It's my understanding. You've been the medical director now for a year and a half, 2
Roughly,
years.
about a little over a year.
Yeah, a lot of refinement has occurred. You've standardized the anesthesia among your colleagues, so anesthesia in general. As far as being able to scale, how critical is that for the anesthesiologist to be standardized?
It's not just the anesthesiologist, that's the whole, getting everybody on the same page, so the pre-op nurse knows where to look, what medication the patient is getting preoperatively. The anesthesiologist being on the same page as to what to use in your spinal, what local anesthetic to use in your nerve block. And then the PACU nurse has to be on the same page with the surgeons as to what pain medication they're going to start the patient on early on. That whole process has to flow.